Okay, everybody.
And yep, it's okay, right. Well, it is 1 minute past 10, so we will make a beginning. Tēnā rā tātou katoa, nau mai haere mai ki hui nei, nā mangai o Paremata, nei rā te mihi, ko Barney Irvine, taku ingoa. Good morning, everybody, and welcome to this online symposium, Sound Investment, What We Can Do to Better Address New Zealand's Unmet Hearing Health Need. Look, first I'd like to acknowledge Health Minister Simeon Brown, who had intended to join us today via a pre-recorded message. Look, the happy news is that he and his wife have had a child. The slightly inconvenient news is that the baby came a little bit early, and hence he went on paternity leave early and wasn't able to get the pre-recorded message done in time. But look, thankfully his team has arranged for MP Ben Uffindell, who's the chair of the Health Select Committee, to deliver that address in the Minister's stead. So we thank Mr. Uffindell for stepping into the breach there. Look, I also acknowledge our other parliamentarians that are scheduled to join us today. MPs Todd Stevenson and Ingrid Leary, thanks for being with us. Look, we're joined today by a wide cross-section of our audiology community, officials, academics, service providers, advocacy groups, and of course clinicians. And look, we're delighted to host you all. For those of you that don't know me, I'm Barney Irvine. I'm the CEO of the New Zealand Hearing Industry Association, NZHIA. For those of you who don't know the NZHIA, we're the industry group representing the main private operators in hearing healthcare. And I'm joined by four esteemed presenters today. Professor Grant Searchfield from Auckland University, Paul Jarvie from EMA, Carolyn Cooper, the Aged Care Commissioner, who was very kindly managed to fit us in her last week in the role. Catherine's busy doing a Radio New Zealand interview. She'll be jumping on shortly. And Senior Lecturer Mike Maslin from the University of Canterbury. We've also got Michael Beerling from NZHIA joining the panel for the Q&A discussion a bit later. I'll get to that soon. Look, it's hard to talk about hearing health without talking about the unmet need and the gap between those who need hearing health care and those who are actually receiving it. And look, as we all know, that gap is comprised of several 100,000 New Zealanders. And look, to set the scene for today, the comment I'd make is that gap isn't getting any smaller. In fact, it's only widening. And on the supply side, look, we're all aware, I think, that the fiscal position is looking increasingly gloomy, or continues to look very gloomy, and that's flowing through into very limited appetite from our policymakers to spend more. On the demand side, we saw that the hearing aid services budget came under significant pressure in the last financial year, as the needs of the ageing population started to be, or were increasingly felt. And look, layered on top of that is we're also starting to get a clearer picture of the scale of the unmet need when it comes to conditions other than hearing loss. And by that, I mean conditions like tinnitus, vestibular vertigo, auditory processing disorder, which have often been overlooked in the analysis. And NZHIA has recently commissioned a piece of work to help shed some light in this area. The findings are out today and have been posted on our website. And what they demonstrate is that there's a large group, a very large group, over 500,000 strong, who are suffering from these conditions, and with very limited funding and treatment pathways available. The system is essentially failing those people. And look, I won't go into it further now. Michael from NZHIA, who's led this research for us, will join the Q&A discussion at the end, so there'll be a chance for him to elaborate on this. But look, I guess for us, it really reinforces that the hearing health challenges is even greater than a lot of us had envisaged, and really reinforces the need for the government to reframe its approach to hearing health. So against this backdrop, you're going to hear 4 different perspectives on the hearing health need today. Grant will look at the opportunity to develop the hearing health research capability nationally. Paul will explore what can be done to reduce the incidence of workplace hearing loss by addressing harmful noise at source. Carolyn will cover the social and economic benefits of improved hearing health based on her years of experience engaging with users. And Mike will explore the role that potential changes to the audiology scope of practice could play. And look, each of the presenters will highlight the need for policy interventions, and a recurring theme is that the investment that we make into hearing health will deliver meaningful social and economic benefits, and benefits that are well in excess of any associated costs. It is indeed a sound investment. And look, sorry, I'm just pulling up this. Look, just I'm sure you'll find the next hour or so really interesting and engaging, and our aim is to help raise collective knowledge and understanding in the sector, both when it comes to the problems and the solutions. Look, I'm just bringing up a slide here. By way of housekeeping, look, microphones are muted. If you have any technical difficulties, I'm going to offer a sophisticated solution. Please leave the meeting and rejoin, or leave the webinar and rejoin. You can also email our IT support at itstar.nz with any issues. This webinar is being recorded and shared, so you'll have access to it afterwards. And as I mentioned before, Q&A will follow the presentations at the end, and please use the Q&A chat function to enable that. So look, that's all for my initial comments. I'm now going to pass it to Ben Uffindell, MP Ben Uffindell, Chair of the Health Select Committee, to provide an opening address.
Symposium. It's an honour to be able to join you today via video link as Chair of the Parliamentary Health Select Committee. I also want to acknowledge our Minister, the Honourable Simeon Brown, who can't be with us today. Simeon has had another child, and we wish him and his family all the best in these special times. I want to take the opportunity to acknowledge and thank the New Zealand Hearing Industry Association for the very important work that you do. Your efforts to raise awareness of hearing health, support people living with hearing loss, and advocate for improved access to services are deeply valued. The commitment and expertise that you bring to this field make a real difference to the lives of so many New Zealanders. Hearing health is an issue that affects between 8 and 21% of people. Unaddressed hearing loss has a profound impact on how we learn, work, connect, and age. We know that unmet hearing need is one of the most significant and often invisible public health issues in New Zealand. Unmet hearing need isn't just an issue of communication. It influences educational outcomes, employment, mental well-being, social isolation, cognitive decline, and falls. We know that hearing loss is associated with impaired cognitive performance, increased risk for dementia, poor brain health in older adults, and untreated hearing loss in midlife has been identified as potentially the largest modifiable risk factor for dementia. Across New Zealand, we have incredibly skilled audiologists, ENT ORL specialists, support services, and more. But we also know the current system's fragmented, with access depending on where you live, how old you are, whether your needs are picked up early, and your ability to afford quality healthcare. We're working hard to improve access to the health system to ensure that everyone, no matter where they live, can access quality and timely healthcare. For hearing health, that means identifying issues as early as possible, setting our children up for good hearing health, and ensuring people can access specialist assessments and treatment quickly. Health New Zealand's working towards a more coordinated, nationally guided approach to hearing health and aligning this with broader system priorities. This includes the Advanced Audiology Practitioner Model of Care to reduce wait times for children with hearing loss and otitis media, GLUEA, who need grommets, as well as for ENT, ORL, FSA services and electives as part of our Planned Care Reset and Restore plan. Ensuring timely access to healthcare services and treatment, meeting the 4-month first specialist assessment target, is imperative for promoting ear health, facilitating social interactions, and supporting language and speech development in children. The current challenges surgical specialists face in meeting service demand are well documented and complex. However, we can reduce some of these challenges and improve access by making better use of our existing health workforce in an advanced scope, such as allied health. Advanced scope allied health-led models involve an audiologist-led approach to increase access to pediatric ENT ear services, leveraging advanced audiology clinicians in lieu of and alongside ENT specialists. By utilising our skilled audiology workforce to assess and treat children between 3 and 16 years of age with non-complex issues, we can free up our ENT specialists to focus on more complex needs. Alongside new models of care, we can also build on the strong foundations that are already in place. The Universal Newborn Hearing Screening and Early Intervention Program ensures all babies are offered a health check soon after birth, with early support available when needed. At age 4.5, children also receive a hearing and vision check as part of the before school check, helping to pick up any issues before they start school. These programs mean we're identifying problems earlier, giving children the best possible start and supporting better outcomes for them and their family. We know there's still more work to do, but with the combination of well-established programs, new models of care, and the expertise of organisations like the New Zealand Hearing Industry Association, we can strengthen hearing health services and improve outcomes for all New Zealanders at every stage of life. Thank you once again for the critical role that you play and for your ongoing commitment to improving health outcomes across New Zealand. I hope the symposium is a great success. Have a fantastic time. Thank you very much. Kia ora.
Brilliant. Thank you, MP Ben Uffendale, Chair of the Health Select Committee. Look, it's time for our first presentation now, and so I'll pass the mic to Professor Grant Searchfield from the University of Auckland.
Great. All right, thank you very much for the opportunity to talk here. We'll go to the right one. That's my last slide. Sorry for that. Get a quick preview of what I'm going to be talking about in a couple of seconds. So, all right. So, I've taken the opportunity to really talk about hearing research. And my perspective here is that we do have a number of challenges which the um, the minister and this report has identified in terms of gaps in our provision of hearing related services. But what I wanted to really highlight is potentially how the hearing related research economy can contribute to the New Zealand's growth, both in terms of addressing unmet needs, but in terms of also potentially generating income and developing ourselves as being seen as a country where investment in research into hearing health can be very profitable. So my talk is really about trying to identify ways that we can make New Zealand a powerhouse in hearing research. So as already has been discussed, we know the particular problems that we face, the high unmet needs, the economic burden that goes alongside of that, the social isolation, difficulty in employment, so on. So we know about these particular issues. We also understand that investment early may then reduce costs in the future. And that is, of course, a challenge in terms of budgetary spending, is spending now in order to make savings in the future. And in case of investing in research, it really is about investing now in many ways, both to enable the growth in this particular field, to bring in international investment into New Zealand, but also to try and reduce the societal burden of hearing loss at the same time as looking forward to future generations and enabling healthy hearing. So, what are New Zealand's strengths for hearing research? Well, we have a national collaborative network in the Oasdale Moore Centre for Hearing and Balance Research that essentially extends out to engage with almost every hearing researcher in New Zealand. So this is a wonderful starting point for having a national initiative in growing hearing research. This network has global leaders in hearing science research. We have in New Zealand an agile research environment. We've got strong clinical links, both with the private sector, but also through Health New Zealand. We have world-class cochlear implant and newborn screening programs that enable us to move forward with addressing serious hearing health concerns, but also planning for the future and management of these particular problems. New Zealand has historically been a place where digital innovation has been tested. You know, the classic example is the rollout of the EFTPOS system, but we see in fintech and other areas that New Zealand is often used as a test bed because of our relative constrained size, but the ability to roll out a national program in different areas within a reasonable sized population that can be used as analogous for larger populations. The other strength is we have Indigenous health leadership. We talk about research in for Māori, by Māori. We also talk about Pacific health. One of the important things about this is to understand that this leadership in the Indigenous space is not just for New Zealand. It can extend out to other populations and extend those learnings and our leadership in this area to other populations within other countries. We do have challenges, and I think we're all aware of some of those. And it's fair to say that the research funding environment in New Zealand is certainly within universities is tighter than it ever has been, certainly in recent memory. We don't have the funding available for hearing imbalance research that countries such as the United States, UK, Australia, and particularly China have. And so scaling up research in this area does need either and or increased government and private investment. We do have a small population, which is both positive and negative. In terms of a commercial market, it's relatively small, but in terms of being able to undertake research that enables us to move into larger commercial markets, it is good for that. But essential for audiology research is the intellectual collaboration and data sharing and our ability to work with other groups. We all have heard the brain drain problem in different areas as the employment market becomes tight. This is the same case for researchers as well. In an environment where it's very difficult to get an academic role following a PhD, we find our best and brightest moving overseas or sadly leaving research entirely. So we do need to invest in these careers and ensure that there is infrastructure to enable people to take on these roles. Another problem is our geographical isolation, which we, again, know that this is an issue for many areas. But if we look at the hearing industry, really the big players in this market in terms of manufacturers and hearing aids are located in Northern Europe and Denmark in particular, and the United States as an example. And it's fair to say that profits from the sales of hearing aids return to these host countries primarily. This means that there's less motivation for those companies to invest in research within New Zealand environment, and we need to try and address that. However, on the brighter side of things, we have lots of opportunities. First off, although we do see the shrinking research environment with regards to government funding, those areas which the government has indicated for funding sit quite nicely alongside the goals of many hearing-related research projects. That is translation of technology or knowledge into commercial products and or services that provide economic gains and high value and or reduce the social costs of hearing loss. We already lead or can lead in specific areas such as tinnitus and hyperacusis, and I'm going to just do a little case example of that shortly. In the area of digital technologies and AI, lifespan hearing care, auditory processing, and as mentioned, Indigenous hearing health. And it's important to understand that there is a global demand for scalable, culturally grounded solutions. So those things that we identify in New Zealand can be transferred and translated to other environments, and we need to harness that sort of thing. So we need to build innovation pathways to enable lab research to go to clinic and then to market, recognizing that the market that we want to actually reach is beyond New Zealand to make it commercially viable. So we need to work with startups, manufacturers, and providers through New Zealand, but also look overseas to investment. We need to support technology development, and we see this more broadly in the digital economy, in digital therapeutics, and also for us, AI-driven audiology tools. And there's a number of pieces of work being undertaken within New Zealand in this area. So I'm going to just lead off with an example of tinnitus that I can talk to more specifically. So New Zealand has a long history of working in the tinnitus space, and we are globally recognized as a leader within this particular area. So this diagram looks a little bit like a spider's web. The circles represent the number of publications from a particular country. The links between these are the collaborations between the different countries. What we can see here is that New Zealand's little sphere here is about the size of Canada. And we can see that proportionally we're not doing too bad, considering that Canada has a population of over 40 million and ourselves with a population of getting close to 6 million, the number of publications that we have. A little bit like the Olympics, we like to compare ourselves on a population basis. If we were to do that, then our circle would be larger than any other circle represented on this page. So we are essentially hitting well above our weight. In terms of treatment-based research, at least according to one publication, the University of Auckland is ranked 7th in the world in terms of productivity, which is an indicator of the fact that even within our restricted funding environments, we can be world leaders. And this is just an example of that. From work in New Zealand, at least two startup companies in the tinnitus space, both digital, Mind Ear, and True Silence Therapeutics. So going into the market, both in New Zealand and internationally, and bringing some of that revenue back to New Zealand in terms of R&D activity and growth. We look broader than that. There are private enterprises in New Zealand that are involved broadly in the hearing space. Earshots is a headphone company that specializes in earphones for mountain bikers and active pursuits. And then there's a earplug company, Sets, that is set up and finding a niche market there. So it is an example that we can enter into the hearing space, even though we are quite remote from Europe. So in order to strengthen this pipeline, we do need to strengthen our audiology training programs. We need to find funding for postdocs and fellowships. We do need to understand that we cannot do everything within New Zealand, and we need to enable seamless collaborations with our international and global hearing leaders. And we also need to consider hosting events and making sure that we are at the forefront of people's minds. Now, we have this Esdale Moore Centre, which is a great template for what we do. Currently, we are funded through a generous gift from the Hearing Research Foundation, but we need more sustainable funding for that, and looking at national and international funding to sustain the work programs that we undertake. We need to, in our limited resources, share our laboratories, expertise, work together with clinical trials, and build also platforms that we can use nationally in terms of data sharing and so on. We need to look at the ability to engage with stakeholders, such as events such as this, that enable us to talk with government, NGOs, and potentially philanthropy. And we should not also ignore the power of the iwi economy as well to meet unmet needs within Maori and the wider population. So what can we do about this? Well, we really need to be a squeaky wheel. We need to tell people how great we are. And you don't need to get me in a corner and sort of berate me to be able to tell you the value I think in the New Zealand hearing research space. Very happy to share that. We need to be able to promote New Zealand-led innovations globally, and we need to work with media and have outreach campaigns to raise our profile of our research within this country. So in summary, really there's a call to action. We have the people, we have the expertise, We have the culture, and we can scale to lead in this particular area. This does need targeted investment and also leadership in this area. We've got a great opportunity to be a global leader in hearing research, and I don't think that the population generally understands what a profile we actually do have internationally in this space, and we need to get out there and be more vocal about that. The groundwork is there, and what we now need is to work forward together on this vision. And so I guess in terms of summary, there are people that are out there that can contribute to this in many different ways through connections, investment, knowledge, leadership. And so through working together, we can really build this into something so that over the next 5-10 years, we really begin to be able to market New Zealand as a true international leader in the hearing health space. And this will lead on to both growth in income, but also related to addressing those unmet social needs, training needs, and so on that the other speakers are going to talk about in this webinar. So thank you very much for your time.
Well, brilliant. Thank you. Thank you very much, Grant. Anybody who attended the Eastern Moor Centre's recent symposium will have a very clear understanding of how great you are. Some really, really impressive research program that has been developed there. Look, our next presenter is Paul Jarvie, who leads the health and safety program at the Employers and Manufacturers Association, EMA, and Paul is very much an expert in this field, and yeah, is described by his peers as a doyen of workplace health and safety. So he's going to share some of his insights now. Thanks, Paul.
Yes, hello and good morning, and thanks for the invitation to come and speak this morning. We're just getting the slideshow sharing. Hopefully that's going to, there we are, I think. Can you see that? No. We're just having a problem there. So look, I know we're running a little bit late. Noise-induced hearing loss. I'm looking at it from a workplace perspective. That's where I work. So I work for the EMA, the Employers and Manufacturers Association, and manage the employment relations and safety space here. It seems as though I've been here for about 140 years, and lots change, but equally lots don't change. So we just need to keep in mind that this is an old story that always comes up and needs to get revisited. So I see I'm on screen, but I'm not sure you can see my screen. Screen one. There we are. I think can you see me now? Can you see the screen? Yep, they can see the screen. Right, okay. Many thanks indeed. Thanks for my little help here. Okay, so let's move on. I'm just conscious of time. So that's the topic. So general background, just touching on, apart from what Grant just mentioned earlier, look, we do have an aging population, and this really is a compounding issue for all medical kind of fraternities, I guess, for New Zealand and around the world. And it's a silent killer. It's a bit like rust. It's there, it keeps on going, and it's profound both in the employment space, but equally in the medical space. So currently there's about 16.5% of the population are over 65. I think that runs out to be about 800 something to 1,000 people every day going on to super. By 2030, that'll be 20% of the population. So if you just think of the aging population with the normal hearing loss things that occur from aging, on top of that, then we've got an aging population with noise-induced hearing loss, and that, as you can appreciate, compounds issues. Finding research for noise-induced hearing loss in New Zealand is, and indeed around the world, is quite problematic. Deloitte's had a socio-economic report in 2016. 800,000 have a hearing loss. That was all hearing loss. Unfortunately, all these reports don't really separate, if you like, the medical hearing loss from noise-induced hearing loss. They make a connection, but it's not actually split out, which is not helpful from my perspective. So we have to rely on ACC. ACC claims between 1994 and 2005, 28,000 claims costing $218 million. There seemed to be a decrease from 2011 to 2015. I have no idea why that would be. I think from about 2010 they increased the threshold for getting a hearing claim, so that might be the reason, but I can't verify that. But when you look at the lifetime claim costs, so these are costs that ACC have to budget for the life of the claimant who has successfully had a hearing claim. So that's running in 2015 was estimated to be just over $500 million. That's a lot of money for hearing loss. 13% to 17% have a hearing loss from noise exposure. And it's the second most common reported occupational condition in New Zealand. I think the key part about this slide is noise-induced hearing loss is the major preventable contributor to hearing loss in New Zealand. So noise-induced hearing loss that occurs within workplaces is predominantly and mostly preventable. And I want you to keep that kind of message in thought as we go through. As I said, most of the research that we see talks about noise hearing loss, but doesn't really talk about noise-induced hearing loss, but it kind of rolls it all together. The World Health Organization put it to about $790 billion, and again, that's all hearing loss. Interestingly, a report from Waka Kauhati in 2024, and again, this is environmental noise, so that's all the socio-economic kind of component. They put the cost there to $640 billion. So we are talking small numbers here in terms of the effect of noise in the environment. And again, there was no in that report. It didn't find anything in terms of noise-induced hearing loss, but just had a comment that significant economic impacts increasing over time, including mental health, quality of life, and reduced productivity. So again, I think the takeaway from all this is we do need to have some targeted research just for noise-induced hearing loss as a subset of hearing loss within New Zealand. So looking at the ACC claims data, so this came out just a couple of months ago from ACC. This is just their kind of infographic. Interestingly, on the right-hand side there, workplace, where noise-induced hearing loss comes from, only makes up 10% of all ACC claims. But looking on the left-hand side, the little bar graph there, the cost of treatment and rehabilitation is increasing profoundly. And those in the know will know that ACC has a real problem in terms of curbing some of their costs. And that's because the treatment costs are going up and the rehab times are going up. But just looking then at the workplace infographic, if we look at the right-hand slide, part of the slide first, they accepted, this is in 2024, accepted 54,000 claims for air. Of the 54,000, 51,500 was for noise for industrial deafness, otherwise known as noise-induced hearing loss. That would have a lifetime cost around about $500 million. So, and if you look at the bottom part of there from Stats New Zealand, just kind of verifying those figures, industrial deafness in 2023, there's always a lag in time there. Put the number around about 4,800, which is 2% of all ACC claims. So it's a real figure. The numbers aren't great in terms of total claims for ACC, but the costs are certainly huge. So this is the data that I could gather from ACC from 2015 to 2024. So these are the claims that have been accepted. So you see the 881, just over 1,000, and going down then to 361, or the grand total on the books of 8,551. The interesting line that below that are the lifetime costs. So once a claim gets accepted, then ACC are required to budget for the lifetime costs of those claims. So in terms of noise-induced hearing loss, that would be repeat visits back to audiologists. It would be further testing. It would be the provision of hearing devices, batteries, and all the things that go in and behind a person with noise-induced hearing loss. From an employer's perspective, though, all monies paid, that's the 28 million, is recovered from employers via their levies within the levy group where the claim is put. So that would be mainly in things like construction, fishing, agriculture, and manufacturing. They would be the majority of the big caseloads for noise-induced hearing loss, and that hasn't changed for years. So I've just kind of graphed that out there. The red dotted line is a 2-year rolling average. So you see it's coming down, but it also looks as though it may be coming back up again slightly post 2022 onwards, but it's still significantly high. I did find a report from Ian Laird, one of my tutors some years ago, back in 2012. So this is the summary of that research that was just looking at noise-induced hearing loss. So the figures are reasonably old, but would be indicative, I suggest. They're looking at 1,000 new cases a year, population prevalence rates of 69,000 thereabouts, 1.79% of the population. That's kind of where we are now, including age-related contributions, up to 2.5%. The non-work exposure. So I think an important part about this report here is a significant contributor to hearing loss, especially among younger individuals, where 60% of lifetime exposure was non-work related. So this kind of suggests from this research that that the younger population is exposed to a lot of noise in their environment. So that may well be going to concerts, going to rock bands, going to social events. We know that people in those days, in the early days, had the Walkmans and the speakers on their heads and the headsets. But what we're finding now is, and I'm sure you've all heard them coming down the road, cars with noise in them, huge speakers in the back. They have noise-a-thons, who's got the loudest sirens. And I don't think they really appreciate that all that is kind of contributing to a slow but continuous hearing loss. So these are the strategies that were identified from the Ian Laird report. So the noise sourcing controls. So we back in 2016 there, or 2012 rather, predominant use of hearing protection was PPE, and that remains today. Nothing has changed in workplace in terms of the mitigation for workplace noise. It's hearing protection. Engineering controls underutilized. We know treating it at source is the best thing to do, underutilized. And admin controls not used at all. So that's varying people's times exposure to noise with quiet jobs. Poor compliance, lack of awareness of hazard management systems, minimal training to employees. I can recall giving some training to some employees, and their rebuttal was their cars were louder than the workplace. So that's what you're kind of up against, I guess. Compliance is not linked to a safety culture kind of climate, and sound level was the only significant predicator for compliance, which means if it was a very noisy workplace, that was the lever to try and get things done, albeit slowly. Legislation and enforcement. The legislation and enforcement comes from WorkSafe. I have seen nothing from WorkSafe in my tenure here in terms of enforcing codes of practice on noise. So it is not on the horizon. It's on ACC's horizon for costs, but not on the enforcement. We do need a multifactorial and a multidisciplinary approach. Totally agree with that. Engineering controls, we know what's out there. We know it can be done, but it is not done. And we need a social marketing and behavior psychology strategy as well. So solutions make noise induced hearing loss prevention a national priority. Never been done. It's been done by ACC years ago. Their publication of a poster on noise induced hearing loss was a failure. Integrate with existing health strategies. I think that's maybe worthwhile. Again, this is from Ian Ledd's paper. And promote best practice. Unfortunately, we don't have too many examples of best practice, so it'll be a very small system to actually bank on. Australia do a lot more, so he cited a case there from FarmSafe, and again, agriculture is the main vector for noise-induced hearing loss. Shift the focus from PPE to upstream prevention. That's the hierarchy of control. We know that. Engineering controls. And the last part, the promote action over assessment. There seems to be a lot of assessments going on, but no action taken from those assessments. So this is kind of more and more research, but nothing tangible comes out of the research. So this is what I could find on the WorkSafe's website. So they do have a code of practice dated 1996. And the dot points there are little publications and guidance on noise at work. The last two dot points is a video there on Harold ears. It kind of gives you a simulated hearing test, and the UK one for experiencing hearing loss. Again, it's there, but WorkSafe never will. I've never heard of it being referred to. Never heard of it being enforced. It's just something that's there for people who want to find it or find it by mistake, and there's no real drivers for it. I did find this report here, Acoustics New Zealand 2016, as another report. So again, this paper here talked about 25% of the workforce is potentially exposed to noise. Again, agriculture, construction, manufacturing, and they also included the military there. There's no standardized certification for professionals conducting noise assessments. So one of the strategies is for workplaces to engage someone to do a noise assessment. It's required by the Code of Practice every 5 years. Very, very rarely done, if at all. And again, this research back in 2016 identified that ACC had paid out 218 million, increasing 20% every year. They suggested in this publication here to improve education, have competent assessors, and promoting engineering controls, admin controls before PPE. And I think that's the message. The cost to employers for PPE and the whole marketing of PPE far outweighs any admin controls or any engineering controls that are done. Even when you make a business case for an engineering control, if there's no budget for it, it doesn't get done. So it just comes down to money and productivity. So this is from that report there, from the acoustics page there. There's a bit of detail on the left-hand side. No reliable information regarding incident and prevalence of noise in New Zealand. I've already made that point. I think we do need to have a real look at getting an idea of noise-induced hearing loss in New Zealand. I do know the Occupational Health Nurses Association. Many of those occupational health nurses do our annual hearing checks, and they would keep records. It would be a good idea to find out how we could access that, anonymize the course to find out what is the real, what's going on within workplaces in terms of hearing loss, because they would do those tests at least annually, maybe every 2 year. And again, this report identified that there's an increasing societal cost, and we kind of know that from research as well. So really, it's a huge kind of problem. And I think I just want to finish up by saying that, you know, Einstein gets quoted a lot, but if we keep on doing the same thing and expect different results, that's crazy. If we keep on expecting business to suddenly have an explosion in their brain, oh, let's reduce noise at source, that's not going to happen. The easiest thing to do is to go and buy some earmuffs. And I think from the public's perspective, we see, or they see, a lot of people these days wearing very small, very effective hearing aids. And I think in their mind is, well, if I do go deaf, I can go and get a hearing aid. So they connect what they see as the solution to being a hearing aid rather than prevention. And I think that's a real strong message that we need to try and change out there. I think we can do better. So I've got nothing more to add. As I said, I've been doing this job for many years, and I think it's sad that we're still saying the same thing after 20, 30, 40 years. Thank you.
Okay, thanks very much for that, Paul. Next presenter is Carolyn Cooper, the Aged Care Commissioner, who is rushed from a national radio New Zealand interview to join us. And again, we thank Carolyn for sharing some insights during your last week in the role. Over to you, Carolyn.
Morena Tato, I'm just trying to share as well. I don't know what the problem is, but it's possibly going to happen. When I push the share, it's not doing it. So does anyone have the ability to share mine?
Yeah, Carolyn, I can share your slides. Just bear with me.
Thank you. I'll just have a bit of a chat first. Yes, I have come from the Radio New Zealand interview straight after Barney was on, and I never caught who it was. Was it Grant that was on before you? Or I don't know who was actually talking.
Duncan Han, audiologist.
Ah, well, it's extremely interesting anyway. I was listening to it while I was waiting for my spot. So thank you very much for the invitation again to talk to the hearing symposium. My role as Aged Care Commissioner is very much about advocacy and trying to encourage people to think about the positive things that they can do about their health. So you may be aware that I have published, well, it's probably upside down, but the Amplifying the Voices of Older People across Aotearoa New Zealand. And in there is a recommendation to increase the hearing subsidies so that people can actually have access to better hearing health. So hopefully at some stage, the government will listen to the recommendations from all of you and from myself and do something about the hearing subsidy that's been decades, not being increased. So I can start without my slides because that's where, they're going to come up anyway. So if you just go on to the first slide about social benefits of hearing. So I just wanted to talk a bit about some of the things that I speak to older people about across Aotearoa. Now, I've spoken to thousands of people in my time as Aged Care Commissioner, and you may or may not know that my time finishes on Friday, so in 3 days' time, or 2 days and 6 hours time. So I have actually had the benefit and privilege of speaking to older people about the things that concern them. And one of the things about my role is looking at health and disability services that impact on older people and that potentially can be changed both by themselves, but actually by their whānau and by the health system. So one of the things I'm really concerned about is the if poor hearing health or poor hearing loss impacts on dementia mate wari, and also in particular the links to loneliness. So we know, and I'm sure you know, because you're in the industry, that hearing loss and loneliness are actually very linked. I experienced this with my own father, that he actually had hearing loss that wasn't corrected, and his degree of loneliness went unnoticed by us. This is many years ago now, and he actually did develop dementia mate wari for probably a range of reasons, but one of them was hearing loss and the other one was loneliness. So reducing the risks of dementia mate wari is very much in my desire, if you like. So we know from the research that there's absolutely significant impacts. In fact, loneliness is as bad for you as smoking. And every time I say that, I actually think that can't possibly be true. And then I reminded myself to have a look at the research this morning, including research from New Zealand, but Harvard research that's looked at, research across the world. And smoking around 15 cigarettes a day, loneliness is actually as bad for your health as that. So I want to be really clear with people that, I think we have the opportunity to prevent the challenges that we have in the health system by correcting hearing loss, by having healthy hearing, by actually looking at those focuses and ensuring that people don't slip into, for instance, not going out anymore because they can't hear in public. I've been told by older people that that is happening to them. And when I actually talk to them about the link between loneliness and health, they're quite staggered about it. And when I talk to them about heart disease, when I talk about strokes, when I talk about your immune system, when I talk about all of those different things, your neurological system, they actually are really shocked. And a lot of people, fortunately, have gone and got their hearing checked. And I see everywhere I engage, and Grey Power would be a really great example because I engage with them quite often around the country and then nationally at their conference. Every time I see them, somebody comes up to me and goes, look, I've had my hearing checked and I need hearing aids and I've got them. There is still a barrier, as we know, around cost. And there are some ways around that, but it's a bit of a challenge. So cognitive health and emotional well-being are really important, but also for older people. And I'm getting more immune to saying over 65 because that's not that far away for me. But that is actually just an age that's eligibility age for super in New Zealand. It's actually not a health-related age, certainly not anymore. And I think we need to be really, really clear that we should look at age groups in 5 years. I would say over 70, 75, 80, 85, etc. And ensuring that there's community participation and quality of life for all of those people. So if you can just pop onto the next slide. Thank you. So we know this is no surprise to anyone, but chronic hearing loss can actually lead to that social isolation and loneliness, which can actually lead to depression in its many senses, and therefore increased dementia mate wari risk. I have spent a lot of time in my tenure as the Aged Care Commissioner of 3.5 years talking about dementia mate wari and the risk, and I'm really clear about the link between the risks for hearing loss and for dementia mate wari. And early intervention and the social support, both early intervention from hearing support, but also ideally if communities can have social interventions for older people, is going to reduce that risk. If we can pop onto the next one. So policy implications in New Zealand, and I think I heard a speaker before talking about integrating hearing health into a healthy aging strategy. If there was a healthy aging strategy or health and disability strategy, it would be great. That is number one in my report as a recommendation. There is no specific health and disability strategy in New Zealand that talks about older people. There are healthy aging strategies and there are better later life strategies, but not specifically about health and disability services. And I think there are 3 particular areas that from a prevention perspective, and hearing loss or hearing health is one of them, oral health is another, and bone health is another. Those three areas are, I believe, important for us to think about from a prevention perspective to improve the health and wellness of older people. We need to increase those subsidies and ensure that there's accessible access for older people to hearing support, assessments and support, and ongoing hearing support. And there are known inequities between Māori and Pacifica and the rest of the population, both in health terms, but also in accessibility for hearing support. So I want to really encourage people to think about that. I've been speaking to many Māori providers. There is a significant interest out there. I've been speaking to iwi. They are already, some of them are already in partnership with some audiology groups, and I'm encouraging that partnership to be more widespread in order to ensure that access for Māori across New Zealand is supported. But the same needs to happen for Pacific communities who don't have the benefit in many cases of that sort of iwi entity that can actually support both financially but socially in terms of getting people together. And we need to expand those public health programs and the education about what we can as individuals, whānau, older people, younger people, what we can do about our health and our hearing health. So next one, please. So there's definitely lost opportunities for the prevention of hearing loss and for prevention generally, and to ensure that there's longevity for people. I describe to many people, and certainly not generally to older persons' audiences, but to other audiences who I speak to, that older people really want to just go, maybe slow, but stop. So they want a quality of life across their years. And at the moment, we know that the last years of life for many older people are not necessarily quality. So we want quality over quantity. And we want longevity for older people. So we need to get these prevention things in place. We need to ensure that people have the ability to do things themselves and to avoid hospital admissions, to avoid things that slow them up, and that they can keep going and going and going. We know that there's a lot of pressure in the system, and certainly in aged care services and in the workforce as well. So there's impacts of inaction to support people who perhaps could have prevented, or with support could have prevented their health deteriorations. Next slide, please. So increasing, I've put this in multiple times, as you can see, because it's actually so important that we make it accessible for people. We know that older people are challenged around their financial circumstances, and that they will make decisions. And I was speaking to some kaumātua on Friday, and they were saying that they would actually make decisions to look after their mokopuna before they actually looked after themselves. And my balance to that for them was to say that, do you want to be around for longer for your mokopuna and in a better health state for them? How about you think about your hearing health, and how about you actually think about the health consequences of not having your hearing corrected from, the loneliness aspects, from the dementia matiwari aspects. A light goes on for many people when they get the information, education that they need. We need to encourage ACC, and you're talking earlier on about ACC and Veterans Affairs support, making sure that there are subsidies there that people can access if they've got the right to do so, and that those are readily available, and promoting the health interventions and social connections. Again, I know I go on about it, but the reducing of the risk of dementia matiwari, it's a personal journey for me. It's something that really resonates to me as well. Next slide, please. Well, I'm actually going to finish early because there you go. That's the questions slide. There's probably a lot I could say, but I'm just going to actually leave it for questions for everyone and give back 5 minutes to you, Dani.
Thank you very much, Carolyn. Much appreciated. And yes, there will be time for questions at the end. So look, I'll pass it now to Mike Maslin from University of Canterbury.
There we go, too. Let me see if I can share as well. Here we go. Is that transmitting?
We can see that, Mike.
Yep. Oh, great. Thanks for the repeat invite. It's lovely to be back. And I just sort of wanted to circle back around to this topic of advanced practice in audiology, which we sort of touched on last time. I think Grant maybe provided quite a substantial backdrop to this topic, and for those who might have been present, the theme being sort of riding the silver wave. We've really framed this whole thing in the context of hearing largely, and now we've got the benefit of this this document to do with unmet needs, perhaps in other areas. So tinnitus, we heard about some of them earlier. Tinnitus, vestibular imbalance, adults with complex needs, and auditory processing disorders, and various matters relating to pediatrics. And so what I thought was it might be a useful exercise to sort of look at the same topic, but through that different lens. And assuming that, whilst in the long run, we might want to hopefully address all of these various areas, it might be that in the immediate term, we need to somehow think about how to prioritize. And so maybe if we had a look through one or two of these, then we can think about how we could go about that priority. That's my daughter, by the way, in the background. She's off daycare with illness today, so hopefully that's not coming through in a disruptive way. Anyway, so any discussion like this sort of wouldn't feel natural without us starting on something to do with prevalence, I guess. And depending on whether it was one or more of those various topic areas that I mentioned, I'm going to use tinnitus as a vehicle or as an example, but you're likely to have some evidence from overseas to do with prevalence, some New Zealand specific, and it may or may not be that we've got a big suite of this information. In tinnitus, we happen to be, I think, fairly well equipped. We've got some prevalence data on the left here from the UK. And on the right, we can see some New Zealand specific data from about the same period. You can see the prevalence is actually, it appears at first glance to be slightly lower for tinnitus disorder or tinnitus overall, I should say, in New Zealand compared with internationally. Another thing to think about is how to rationalize, how to merge these pieces of information. So in this case, we have survey data from a questionnaire where people were asked, do you get noises like ringing or buzzing in one ear or both, lasting X number of minutes? On the right, I think it was a phone survey-based type of approach, and people would be just rung up and sort of asked, do you experience tinnitus, yes or no? So you might get, differences like that in terms of, actually, I don't think these are giving us a different message per se, but again, just thinking about linking information that we've got to guide us on that priority type question. Of course, prevalence data on its own doesn't necessarily, tell us about the unmet need as such. We might need to link it to something else. So what might be the burden on society or the burden on the healthcare system? And so to just illustrate that again with this sort of tinnitus example, I'm just referring to this other more recent study. And what I like about this one is that they've set to define tinnitus according to the help-seeking behaviour of the respondents. And so what you can see is that a larger proportion of people with severe tinnitus would seek help compared with milder tinnitus or none at all, and that makes sense. But what stands out to me here, again, in relation to that unmet need, we can quantify the number of people who might have severe tinnitus but aren't accessing support networks. And, then we can ask, well, why is that? Is it because they're not aware? Is it because those resources are stretched too thinly? Is it because the answers that we have available isn't sufficient or appealing to that person? So again, this is another way in which we can link and quantify and help to make a priority kind of decision. And then, of course, we have things like modeling the cycle of impacts. We have some examples here that relate to hearing health. I think we've got quite a lot of comprehensive models here, but perhaps more of a patchwork scenario in some of those other areas that we've mentioned. Now, one thing we don't appear to lack is a range of concrete examples of where researchers and clinicians have sort of stepped up and probed and aimed to demonstrate how some of these healthcare efficiencies in audiology might be met by advanced practice models in one way or another, whether it's balance, whether it's across some of those pediatric areas. And that's a really good example that we have in New Zealand is Michelle Pokorny's work in Counties Manukau, where the idea there is an audiologist working to perform routine post-surgical follow-ups, for instance, in children with middle ear surgeries like grommets. And again, another kind of factor that we can weigh into the mix is looking at things through, for example, an equity lens. And you could imagine there could be some communities where the impact of these practice changes could have an outsized effect compared with others. And then finally, we might think about the economic argument. And again, we perhaps might have a little bit of a variable makeup of information in tinnitus. We don't have, as far as I know, any New Zealand specific burden of cost to society. There are some examples from elsewhere. For example, this one that I'm showing in the middle that comes from the Netherlands and sort of scaled for population size differences and inflation and so on, then approximately 3.5 billion New Zealand dollars in terms of direct healthcare costs and indirect. So one thing that one general observation is that we do, in terms of the numbers of people working in audiology, we seem to have sufficient capacity. I think there was a projection from Exeter and others, which Grant Searchfield, I believe, was involved with about 10 years ago, projecting the number of audiologists we might need in relation to the population size projections. But where we might not have such a grip is, or where things might develop, would be in stratifying this workforce. And so that's again in the area of advanced training pathways available to address some or all of these matters. And that sort of circles me all the way back around to what I had the chance to talk about a little bit last time. And that was in relation to what we currently are able to provide to support such a stratification, so provision of short courses and credentialing. And I think it's fair to say in the two audiology training programs that we have, there's a great desire and interest in academics that like to be stretched and like to teach at these advanced levels, presuming that there's a sort of business case. And so it's kind of I see it as a conversation that needs to coalesce forward with these teams working together, but also across disciplines as well, thinking about the knock-on effect of, if you like, changing the scope of practice, modifying practice in one discipline might have an impact in some of the side disciplines like ORL or audiometrists. But anyway, so hopefully that sort of gives a little bit of food for thought. Not necessarily saying I had all of the answers there, but you know, what evidence base might we have? How fragmented is it? What how do we build a case for one area for advanced practice to be prioritized over another? What might the outcomes look like? And that feeds in, of course, to governance and audits as well. If anyone would like to have a look at any of those references in relation to tinnitus, then I've just flashed up these resources here. But that was everything I had to offer there. So thank you.
Brilliant. Oh, thanks very much, Mike. Look, we're in a really healthy position in terms of time, which is always nice. So look, we're going to transition into the Q&A sort of phase. But look, before we go there directly, what I'd like to do is give Michael Beerlin from NZHIA the floor for, well, let's make it about 4 minutes, I think, Michael, if that suits you okay, to talk about the research that he's recently carried out for us. And look, while he's doing that, could I invite you all to please just reflect on any questions you have for any of our panelists, our presenters today, and put them into the chat, the Q&A chat, and then we'll save the last sort of 10 minutes for questions to presenters. So yeah, over to you, Michael. Great if you could provide a very quick overview of your findings. We've touched on those a bit already, and then I suppose reflect on what you see as some of the key elements of the policy making response.
Sure, Barney, thanks. That's great. So what we were tasked to do was to look at demand for complex hearing health services, and what we found is essentially that the population demand is growing for these services because of a growing population, but also an aging population. But the service provision isn't necessarily keeping up, and it's not keeping up for a number of reasons. It's not keeping up because funding isn't tied to the level of demand, so funding isn't following the growth in the population, and that's somewhat surprising from my perspective because population predictions have been known for quite some time. So you'd expect there to be a design element there that should be built in, and it's not being built in. And certainly we know that funding needs to follow demand, otherwise people get left behind. And particularly in an area where there is some reluctance for people to take up certain kinds of support, such as hearing aids, you've kind of got one chance to get them on board. So if you're putting them in front of a clinician and then asking the clinician to defer the kind of services you're offering because you need to wait for next year's budget, that's very problematic. Because will these people come back? Will they have trust and confidence in the system? And in the meantime, their hearing health quality, their general life quality is undermined. So I think we need to look at systems where funding certainly follows demand. And absolutely, Paul, your point on prevention is critical here. I think there's a clear case to look at noise-induced hearing loss much more carefully. So yeah, absolutely, we found that there's a growing gap in demand between demand and supply for hearing health services, and that could get worse as the population ages. What we need to do is look at really 5 key areas. I would say prevention is key, but also the scope of practice reform is critical in all areas of health, but especially in audiology and hearing health services. We need to make sure that people are working as close as possible at the top of their scope of practice, so that we can get the best value out of them. Then we need to think about, are we providing the right level of data and research around this area. Grant, your points are very well made that there needs to be more funding for research. And throughout my project, I keep finding a range of data gaps on some of these more complex areas that need to be addressed in more detail for New Zealand and for New Zealand's diverse population. Certainly, I think access is key. We can't have a health system that works based on where you live. It needs to work for everyone. And so we need to look at what's been done overseas. And some examples are co-locating audiology services within GP offices as well, so that if you arrive at the doctors with a hearing health need, that can be directly addressed, that you don't have to go off-site. And that's particularly relevant for people that might also have complex challenges with transport and moving around. You need to be able to get direct access, and I think you can get direct access in New Zealand if you go privately to a clinic, but we need to lower the barriers by removing the need to go first to your GP and then get some kind of referral. And also, I think we need to think about national cover. I mean, the Danes, for example, just stood up 300 clinics around the country because they realised they weren't getting enough national coverage to meet the needs of their population. And lastly, of course, we need to think about how we're addressing funding to ensure that both we're getting funding for research, we're getting funding for prevention, and we're getting funding for lowering the barriers. If you look at the UK and also Denmark, hearing aids are essentially free for those who need them. In New Zealand, the barrier is somewhat higher. They're getting a level of support, but not the most support they could be getting. And I think, as we've heard today, that barrier needs to be lowered and needs to be lowered consistently. I'm at risk of rambling on, Barney, but I think
okay. Well, look, thanks, Michael. That's really useful. Let's give a little bit of time for questions now. And look, let's start off with one for Carolyn. And I suppose this speaks perfectly to the theme for this event, which is sound investment. And the question is, do you believe the costs associated with dealing with or addressing the unmet need, such as increased aged care and dementia services, would provide savings that would provide savings that outweigh those investment requirements, and if so, is this a current governmental conversation?
The answer is clearly yes. I think what needs to happen at some stage is there needs to be a conversation about the quantum and how you could actually be able to define that. But absolutely, trying to ensure that people have the opportunity to prevent issues happening by, for instance, their hearing health being improved are significant things that need to happen. Are there government conversations? Well, there are from me, but there's not a lot of other people talking about these sorts of things. So whenever I speak to ministers, or I speak to Te Whatu Ora, or I speak to ACC, I speak about hearing health. When I speak to people in the system, that is one of the particularly 3 topics which I talked about before. And I truly believe that we have to look at the risks associated with not correcting some of these things and have some way of trying to demonstrate the economic benefit to prevention in the older person's health and disability services.
Great, thanks for that. Look, we'll continue that theme. We've got a question here from MP Todd Stevenson. Just asking, well, accepting that there is accepting there is a significant economic impact from hearing loss, has any specific work been done on quantifying in detail the potential fiscal savings to the government from any investment, and separately the wider societal benefits of the investment? Look, I'll answer that one very quickly, which is yes, a chunk of work has been done. And I'm aware of at least one piece of work which we sponsored NZHIA to do a couple of years ago, which was very good. And what it really emphasises is benefits worth into the billions each year in terms of the contribution to GDP as a result of increased employment, increased productivity, and reduced loneliness and isolation. And Carolyn's touched on those, direct flow-on impacts of those conditions. So, Todd, I'll really happily share that with you, but I think it's certainly an area we need to work on further. Look, I'm going to jump to another question from Michelle Bacorni for Paul. What public health approaches might be effective for reducing noise-induced hearing loss? It seems that education and personal small business responsibility are important, but unlikely to shift the curve sufficiently.
Yeah, thanks for the question. A very good one. Look, I think we really do need to start educating our kids at school, because trying to educate them when they're at work with all the pressures of work and being kids and young parents, it just doesn't kind of wash with them. So understanding right from an early age about noise, the effect of noise, just in simple terms, then they understand as they progress through life when they're exposed to noise and what they can do about it. So I really think that a public health campaign would be absolutely beneficial if it was augmented with other strategies to make sure that it's ongoing, because having been on numerous government committees, it's a 3-year cycle and then it stops. So these things have to be built in and for the long haul. Almost a whole generational kind of change needs to take place. Thank you.
Right. Mike, I'm going to put a question to you now. You've talked about advanced audiology practice approaches and scope of practice changes across complex audio or hearing health conditions. Which of those conditions would you prioritise? You've mentioned. Sorry, this is for Mike Maslin. Sorry, Michael. Which of those conditions would you prioritise here? Tinnitus, vestibular, or vertigo, or APD?
Yeah, thanks, Barney. Yeah, well, yeah, I don't know if I have the answer. I use tinnitus, and I suppose to some extent I'm a little bit biased. I use tinnitus as the vehicle to try and illustrate some of my points, and offer a framework for how that question might be answered, weighing up or weighting some of the factors. One thing that I sort of didn't mention is how easily might it be to integrate an alteration in training, in scope of practice with what we already do well. So if we think about hearing loss as something we do relatively well, then what would sit nicely alongside that? And I would perhaps suggest, tinnitus would be a good example, because we know lots of people with tinnitus do ever so well with a hearing aid as well. But then there's various other pediatrics. I can see again Michelle's got a comment in there about that in the Q&A, and how we can judge outcomes and have a yardstick for success from some of these reforms can also be into the mix there. And I think what Michelle's demonstrated is that that's relatively easy to not relative, but it's relatively clear cut how that how that yardstick for success can be measured. So yeah, I think there's lots of scope for that conversation.
Yeah, great. Look, We're 1 minute away from the close of our event. I think it's probably we've got piles more questions in the Q&A there, and to an extent it feels like we're just getting started. I think there's probably a lesson for us in how to approach this for next year's iteration. Give ourselves another half hour for Q&A. I think we'll certainly do that. But look, I think it speaks to what an interesting and rich conversation it's been this morning. Just a few insights that really stand out for me very quickly. Look, we've heard from all our presenters really about the need for new approaches and new ways of approaching these challenges in a range of different areas. I think that's critical. All of our presenters have touched on the need for a mindset shift from policymakers and really making hearing health a critical public health priority. And I guess, as I see it, it falls to all of us to really make the case, and this came through in a number of the questions towards the end there, really make the case for increased investment into the sector. And I think, yeah, it falls to us to really push that message to government that this is very much a sound investment. So look, I want to thank all of our presenters for giving up their time and contributing their expertise. Really appreciate your input, and it's a real pleasure to work with you on an event like this. I want to thank all of our participants for joining us today and giving up your time. As I said earlier, we'll share this recording, so you'll be able to go back through it and please share it with your networks. And please feel free to get in touch with me. If you don't have my contact details, you can easily get in touch through our website, and I really look forward to continuing the discussion with all of you. Ngā mihi kia koutou. We'll talk to you all soon. Thank you.